We have respect for the change management that is required to bring forward these new technologies and allow our care teams to really merge them into their current day-to-day practice. It's not about just putting them through some horrible modular training, but about actually bringing them to a level of understanding and being a part of the decision-making of how we're adopting this technology, how we're blending it into their day-to-day, how it's making their job easier, how it's changing their job.
Welcome to The Other 80. I'm Claudia Williams. It feels like every day we're hearing a new pitch for how AI can change the game in health. Many of these are frankly fever dreams about how technology can magically erase complexity and fragmentation. It can't. But my bet is on primary care for an area where AI can produce real impact on health outcomes, patient experience, and physician burnout. In this episode, Kameron Matthews and I sit down at Health. We talked about Cityblock's focus on taking the complexity out of primary care for marginalized communities. They do this with people and process, but also with AI. Please welcome Kameron Matthews to The Other 80. So nice to have you here.
How are you?
I'm so good. Let me be honest. I'm a little tired.
This is a tiring meeting. You feel energized, but it's tiring.
Super
Just
tired.
the sheer number of steps.
I feel like our lives and the work has many intersections that I hope we get to today.
Yes.
But my first question is, what's important to know about you?
What's important to know about me? I love calling myself a second-generation family physician. I love that I'm the second Dr. Matthews. And I think over a lot of interviews I've done over the years, I constantly reference my father. I just can't help it that he really, both of my parents really, but my upbringing gave me the opportunity to focus my career. They never denied me any opportunity to achieve, to seek out additional education or experiences to become who I am now. So I love calling myself second generation because it just denotes that history. I am a very proud Black woman. I will say that loudly and assuredly. I love my community. I love my culture. And I love when I then combine the two, being a Black woman physician. I love that I'm able to focus what I do with an eye on a future that I think hopefully we all agree is attainable more than anything. And then I'm a sister, I'm a wife, I'm a dog mom. I love all of my identities.
So we're going to start with Cityblock.
Yes.
It's a very interesting, multifaceted model.
Yes.
The framing that I think you've used before is that you're an advanced primary care model serving Medicaid and dually eligible patients, taking capitation. What does it actually look like? And what are the pieces of the model that are important to know about?
We are at the core a primary care practice, like you said, an advanced primary care practice, which I'll describe, but really afforded the opportunity to focus on relationships between our entire care team, not just the provider, our entire care team and the people that we serve. We're providing them primary care services, not always as the assigned primary care provider. They may have another relationship in other parts of their ecosystem, but we're there to really assist, fill in the gaps, and address usually some of the inequities that they've been facing. We do this through an interdisciplinary care team. So again, it is not just the provider, whether it's a physician, a nurse practitioner, a physician assistant, taking care of that patient, but it is also the nurse care manager. It is also the clinical pharmacist. It is also a slew of amazing behavioral health staff, whether it's an actual psychiatrist, a care manager, or the like, but we're all doing so in an integrated fashion. So we're interdisciplinary and we're integrated so that this isn't just about referring between different expertise on the care team, but this is about coming together in a holistic manner to help formulate treatment plans based on the priorities of that individual person who's at the center. So being advanced, that means we're doing a bit more than the average primary care practice. I trained in and practiced in and helped lead several federally qualified health centers.
I was going to say.
And exactly. We pride ourselves in the FQHC space to offer one-stop shop care, right? That we are bringing together multiple fields, primary care, behavioral health, dentistry, and oral health, and addressing the social needs of the patients. That's what we're doing at Cityblock, but to another level. We're doing it at a population level where we're taking risk and really responsible for outcomes, total cost of care, and quality. So therefore responsible for all care that's even outside of our walls.
So let's shift focus to the business side.
Yes.
Who do you sell to? And what markets are you in? And how does the business negotiation work? Because there are a bunch of, I'm hoping, would-be entrepreneurs out there that are like, I want to do this too. This sounds awesome.
Yes, come find us. Yes. So we partner with a variety of health plans and currently are in 7 markets, 7 different states. So Brooklyn, New York is where we started, but we're bridging into the Bronx as well too, and actually have members across all 5 boroughs. We're also in Massachusetts, North Carolina, Florida, Ohio, Illinois, and Indiana, and a couple of new markets near you in the coming year, which I'm not yet going to share. But it's interesting, especially being in the Medicaid space, the difference between the markets, the states, the regulatory environment. There's some similarities that we're able to obviously provide the scale of our care model, but then we have to obviously be uber focused on the local needs, both clinically and for compliance reasons. And so our partnerships are pretty critical. We have an attributed population with each of those health plans. And we are, again, focused on improving outcomes, improving quality of care, most importantly, closing those gaps, managing chronic disease, but then decreasing avoidable cost as well, too. We're not that gatekeeper. We're there to help right-size the services and make sure the members are getting the care where and when they need it.
You have at least 2 lenses, I'm sure. There's the plan,
yes.
The plan buyer.
Yes.
And then there's the Medicaid is a mostly a state and federal partnership.
Yes.
But it's state design.
Yes.
Are there characteristics of state markets that are beneficial to what you're doing or not? What do you look for in a state market?
The general environment that we seek out is one that is open to the partnership that we would bring with the health plan. So there are definitely some geographies, states that are not yet as fully invested in value-based care in the Medicaid space. That's really the crux of it. We are happy, like I said, to be in North Carolina, a state that just opened the doors to Medicaid expansion. So that in and of itself is not a barrier. We would be open to the 10 other states as well too. But it's really about their openness, their willingness to allow for these partners in a value-based setting. And not every state is fully ready for that sort of partnership.
I've had a couple chief health officers on the show.
Lovely.
And it always brings the question up, what is that?
I know,
and
the
how
title.
is it different from a chief medical officer?
Yeah.
And how do you think about that?
Yeah, I look at it really an expansion of the CMO title, the traditional CMO title, where I'm responsible for the health of our patients, not just the medical care. So I'm responsible for the clinical delivery, the larger care model, how we're approaching their population health outcomes, but doing so beyond just the traditional definition of what we physicians declare as kind of the medical scope. So I am working closely, of course, with our nursing infrastructure. I'm working closely and focusing on how we're addressing social drivers of health, which, there's plenty of conversation about how, whether or not that's within the lane of clinical care. I say it firmly is, and that the impact that we can achieve by having resources around food as medicine, around housing and transportation and broadband access and the like, that is equally as impactful as what prescriptions I might write or what diagnostic tests I order. So chief health officer to me is the necessary expansion of moving beyond just what is traditionally defined as medicine.
All kinds of results have shown that actually the physician-driven, the primary care-driven models are the ones that achieve the health outcomes and the cost savings and have aligned incentives to get to the outcomes we want for good reasons, right? So it'd be great to have more of those. And you're focused on the Medicaid market, but other folks are focused on other commercial, on Medicare. Mm-hmm. And you've also been, I think, really generous in saying we want more people innovating in this space. We want more primary care-driven models. We want to see other businesses build and thrive. And so what advice would you give to people building a primary care-driven venture-backed model? And then the second part of that is, and focus on Medicaid. What would be your constellation of advice for those folks?
I think first and foremost, the model, the design, the workflows, the business and clinical model, needs to be designed for the community that you want to serve. One size does not fit all in healthcare whatsoever. And there are differences in needs. There's differences in focus, in resources, in expertise that you'll need in your workforce within marginalized communities, within different geographies that needs to be heeded and needs to be designed for, as opposed to taking another primary care model and applying it to this community. So equity by design is something that I am seeking out at all times, not just equity by default. I think for us, recognizing first and foremost, before you address any clinical concerns, we need to earn the trust of the people that we're serving. They have been marginalized, not just within the healthcare system, but at times within their own communities. They've been traumatized at times. And again, not just physically, emotionally, as we think of trauma and trauma-informed care, but oftentimes traumatized by the healthcare system that is meant to be serving them. So first and foremost, our ability to lean in and assure that our workforce, our teams are engaging with these members to earn their trust, to earn the right to then deliver them care is for us pivotal to our success. They need to believe in our incentives for being there, for standing shoulder to shoulder with them, for entering their homes, for accompanying them to their other services, specialty care, meeting them in the emergency room. They need to believe why we are there is for their best interest. And so we have designed our model, a lot of our outreach, our programs with that in mind. If we just jumped in and applied another primary care model, perhaps that a health system has put in place for another community without recognizing that pivotal piece, we would do a disservice, not just to ourselves, but to the patients that we're serving. Other area of focus around how we integrate, how we, like I described around FQHCs, how we actually bring all of our services together and make sure that we're not expecting the patient to navigate themselves between different services and the like. That, again, is with the communities that we're serving in mind, that they are often shuffled and shuttled and referred and all of the different verbs where the burden is placed on the patient to figure out the healthcare system. And we know, quite intimately, I know, that the system is so difficult to navigate even as someone who understands it. So someone who doesn't necessarily have that father, that family member that can help them navigate, they need that additional supportive hand. And so we really lean in as a care team to offer that as well too. So all of that is designed specifically for the communities that we're serving. So I would recommend those who are looking to address health equity, focus on specific communities. They need to design with the people that they're serving in mind and not with a one-size-fits-all approach. It was hugely apparent my prior role at the VA, Designing a model to help veterans is an entirely different approach than it would be for a non-veteran population. Acknowledging their military service, acknowledging what healthcare needs they may have and how they might differ from a civilian population. That is where the success of the VA as a health system comes from, because we have designed our model, how it's integrated, how it is stood up, how we prioritize and engage with veterans. We've designed it with the veterans in mind and with veteran input. Again, point to these examples as opportunities for founders, for creators to really think through not just seeking out an expansion of their TAM or what's the easiest approach to business by jumping into a space perhaps that has the largest addressable market first, which we know what that is. But instead, if the goal is to address inequities and to think about those different marginalized communities, design with them in mind first and with them at the table. Nothing for us without us. Again, FQHCs do this. The VA does this. This isn't unique to us, but we within our practice have truly built it as a functionality that is part of our design process, as opposed to something that's just a gather reaction, or that's really secondary to something that had already been designed and now you're seeking out input. Actually, no, input needs to be at the beginning of the design phase. And like you said, that's a critical component of any human-centered design approach. But we're doing it through targeted input and ongoing input, more importantly.
One of the things that's bubbled up a few times in our conversations on this podcast is, I think, the work in equity and social drivers is recognizing that there's so many other aspects of our lives that create opportunities for health or barriers for health, whether that's food or what our work stress is like, or our access to even money for housing or whatever those things are. I think Medicaid has been really creative and a lot of states in trying to think about how to integrate that with medical care. But then people have made the observation, well, if we take a service mindset, you're still focusing on an individual and their service needs versus on the underlying system. So you're delivering a meal, you're not focusing on food systems. You're delivering a voucher, you're not making more affordable housing. And on the one hand, I don't want healthcare to feel like now all the world's potential problems are on their shoulders. Mm-hmm. On the other hand, if we replicate a medical approach to delivering social services, we won't ever fix those underlying things. So I'm just curious how in your work you think about that question.
I think the solutions have to come through partnership and creating systems in local communities, bringing all of the different potential partners with impact on health, not just those who are involved in health care, but with an impact on health, bringing them all to the table to devise solutions and to bring down the siloed walls of, as your example stated, if patients over here are seeking out food assistance and we have a food bank or some other wonderful community-based organization providing those services, how can those two organizations communicate to optimize? How can information be shared, data be shared? How can there be a closed loop scenario so that we can assure that action is taken and opportunities can be followed up on? I've been a part of those conversations in some communities where we're recognizing it's not that healthcare needs to be the entire total solution to each of these issues, but we need to be at the table and we need to bring those other partners to the table in order to bring around some real policy change and some systematic approaches to solving the problems. The one conversation that comes to mind, it was also very interesting because we were bringing together several nonprofits, government agencies, as well as, I won't name the city, 3 very large academic medical centers came to the table. And they're all treating the patients in the same zip codes, but they're, of course, competitors at the table. And we had to put, kind of as a rule of engagement of the conversation, leave your title at the door. This is about a community approach. This is about not necessarily promoting your volume and your achievements and your statistics over another, but how can we as a community figure out solutions through partnership? It's been a rocky road, those conversations. It's not always aligned, unfortunately, with the larger business goals of those individual medical centers. But that's the necessary approach. Again, having the government entities there, having private business there. Banks were actually at the table. Banks weren't even thinking that they were part of a potential health solution, but we needed to talk about how they were going to potentially support the nonprofits, think about funding different solutions. It was a wonderful conversation. It was the first time that I had seen the broader definition of health being brought together as opposed to the sheer focus on healthcare delivery.
Yeah. And did that continue?
Oh, yeah. Oh, it's standing meetings.
Nice.
Yeah, it's standing meetings.
And it's also interesting, as I've been digging more into housing and into food, and we're not the be all and end all of complexity. They all have their complexity too. And I think we often have, and I was thinking about Paul Markovich's statement earlier, he's like, when people come to me and say it's complicated and they think that their contribution to solving it is explaining how it's complicated versus trying to solve it. So some of what needs to stay at the door too is you think your complexity and your bureaucracy and your rules are number one.
Yes.
Everyone has those.
Yes.
We need to figure out how to navigate across those. And
how do we find initial simplified quick wins, right? To be able to bring down those barriers, to think through maybe some initial complexity. I mean, yes, these are difficult questions to answer around poverty and lack of resources. Yes, but there's still gains to be made through partnership.
Yeah, totally. The podcast station at Health is immediately next to the AI Pavilion, right?
Yes.
And you were on stage yesterday talking about primary care, but also you wear hats and have been really driving a conversation about the role of technology and AI adoption within primary care. Exactly. That's not the first place we think of.
No, it is not. I was just having this conversation.
It should be. I mean, if this is where we're going to be improving health for Americans, it has to be there. And I want to start by asking, how are you thinking about that within Cityblock? And what are some of the interesting examples that you've been starting to launch? And then we'll talk about your broader work in the space.
Yeah. Our model is only going to improve further the more tech enablement that we're able to bring to the table. And that tech enablement is not just about patient-facing opportunities or even clinical decision support, but just even the background of removing that administrative burden that our care teams are faced with. I mean, we know this in healthcare, the waste, the documentation, the amount of data that needs to be kind of forensically approached, and how we're actually helping these very complex patients, understanding their backgrounds, so we can then recommend treatment plans in the future. That takes an awful lot of resources to be able to understand, to comb through, and to act accordingly. And so we are leaning in on having different platforms that include AI to really assist our care teams in taking care of our members, in allowing them to do what they do best as humans, because they don't have to waste the hours of time combing through data or managing documentation. It's really about, again, allowing our humans to do the work that they are trained to do, and using technology to take away some of the other workload that really doesn't require a human to do it. I don't need to sit there and comb through PubMed to find resources and articles that may be used to address a very specific medical condition that my patient has in front of me. I can really, think through with AI and even submit more really specific data around my patient and have some solutions brought forward. It doesn't mean that I'm less of a clinician. It means that I'm using a technology to comb through a massive amount of information that just even in the last 10, 20 years has exploded. What we are responsible for as clinicians, as we know, particularly because of the errors that occur in medical care, the information that we expected to hold is a bit beyond what the human brain has capacity to manage and analyze. So why not have something in your tool belt to help you get through that data? So we're looking at other solutions, like I said, because in this value-based space, I need to understand what's occurred to my patient longitudinally, no matter where that care occurred, combing through that data, the hours that it could take to read through PDFs of discharge summaries, specialty notes, and the like. Let's throw some AI on that. Let's have a tool present some information to me that I can then work with the patient and the rest of my care team to get what needs to be done at the forefront, as opposed to spending hours of my day researching.
Are you finding your clinicians are pretty open to these? I mean, especially I can imagine if it's helping take burdens off of them.
Yes.
But you're finding they're open to that.
They are. And it may be a function of the clinician that has kind of self-selected to come to a Cityblock where they know that we are looking to be tech-enabled. But I think also, we have respect for the change management that is required to bring forward these new technologies and allow our care teams to really merge them into their current day-to-day practice. It's not about, as we have seen for years with EHRs, it's not about just putting them through some horrible modular training, but about actually bringing them to a level of understanding and being a part of the decision-making of how we're adopting this technology, how we're blending it into their day-to-day, how it's making their job easier, how it's changing their job. From past experiences of other EHR launches and the like, I've been fortunate enough to see it go wrong. And so really have a focus with our care teams about how it's not just about choosing the right technology, but how you actually implement and assure that every person on the care team is not just comfortable, but feels some sense of ownership and acknowledgement of how this will make their job easier.
My last interview at Health is with Mickey Tripathi.
Oh, wonderful.
Who's the new Assistant Secretary for Technology Policy. And I guess he's the Chief AI Officer for HHS until they hire somebody.
Yes.
What questions should I ask him? What are the questions you have in mind that have to do with the bigger policy setting?
Yeah.
And then we'll talk about your role.
Yeah. I am very interested in how they see their role from a protective lens more than anything. How they will assert themselves, whether it's through regulation or accreditation or some other format, to really assure that we are still providing safe and effective and reliable care to the patients of this nation. We as clinicians are expected to have a level of ethics and focus on evidence-based medicine. We have an infrastructure in which we practice. How are they going to create that infrastructure from a digital health standpoint?
So you have a leading role right now in CHAI. So talk a little bit about what is CHAI and what are you doing?
So Coalition for Healthcare AI, Brian Anderson has convened what we call a Coalition of the Willing, where we're bringing together health systems, academia, business, to answer some of these questions. How do we propose an infrastructure so that we can assure that healthcare AI is safe, reliable, effective? I'm brand new at this. In fact, when they asked me to step in to co-chair this advisory board, my eyebrow went up. I'm like, are you sure that... Because I have no background beyond being in the tech-enabled space that Cityblock occupies. I really haven't had the background in the more kind of informatics space, the AI space, the digital health space. I'm learning as we go. But what I am is a primary care physician that has an invested interest in assuring improved population health and health equity. And so for me to apply that lens in this AI conversation, I'm ecstatic for. So I said, you know that I'm going to be advising from a very different lens. And they were very open for that. That is actually the goal within CHAI, to bring everyone to the table, to bring the different stakeholders, to propose the model cards and the assurance labs, and to assure that hopefully some strong proposals for Mickey to consider and the rest of government to consider, so that we can, again, approach AI with some real consensus in mind. So I'm learning as we go. Like this is again brand new for me. I'm reading every document, every word with just eagerness, and I'm really excited to be a part of it again from a primary care lens.
I interviewed Ziada Obermeyer about AI and health and bias. And I loved what he said. He said, okay, if I was a CEO of a health company, my first question would be just what algorithms are being used today in my company to create health for my patients, and know what they do.
Yes.
And ask the companies, your vendors, what do these algorithms do? Because he said, you don't have to understand the mechanics of it, but just what's already even in play.
Yes.
Because often you won't have chosen those things.
For me, it's the additional what data was used to train those algorithms, to create those algorithms. The biases that we have in our healthcare system will be reflected in the data that these models are trained on, unless we are quite intentional to assure that there is a broader span of data being used to train them. So I have been very adamant, and I'm lucky to have spoken just yesterday with Q Ree, who's the president of National Association of Community Health Centers, who I remain a huge advocate for, that NAC needs to be at the table.
Yes.
That the central hospitals need to be at the table, that the government entities need to be at the table. This is not just about bringing the fancy informatics departments to the table to create this sense of governance, but that every potential stakeholder who could be using one of these platforms needs to voice their concerns, ask their questions, and be assured that their needs are being addressed.
I have this incredibly lucky position now. I'm the Chief Social Impact Officer at Berkeley School of Public Health, and we're building a community of students that really want to make and create and build as their students and also learn these skills. So you yourself were a student leader.
Yes.
And you talked about how that really was your foundation of leadership.
Yes, it really was.
At that somewhat early stage in your career. What were the things you learned then that have stood the test of time that can help us figure out how to build that for students today?
I love that. So I was the national president of the Student National Medical Association, which is the organization across all medical schools, both allopathic and osteopathic, for underrepresented minority students. I was proud to serve, such a large constituency. And what I learned from that space was how to be a servant leader, how to honestly manage my time as a student to be able to lead such a large effort that included advocacy and academic affairs. Like, we are a student organization, so we needed to support our students in how they're actually achieving in medical school. To be able to manage my time and to work with a staff, to run meetings, to run a national conference and the like. As a student, that was, I think, as I've said before, more educational than a classroom setting, because I was able to make mistakes.
Mm-hmm.
I was able to have this environment where I could learn on the job. And I think I definitely encourage students to seek out leadership positions where they can gain that preparation. I think there's a set of transferable skill sets for students that can be learned regardless of the subject matter. It doesn't even have to be a public health focus, that they learn how to advocate, that they learn how to communicate, that they learn how to partner. It could be through any means of organizational involvement that they could learn skill sets that they could then apply in the public health space.
I love that. Well, on that note, thank you so much for joining. It's been so
Welcome.
And when are you going to be in my neck of the woods? Please reach out. I
definitely will.
Okay.
I definitely will. I just was fortunate enough to get a volunteer appointment with UCSF. I know that's not completely close, but I have a tie to Cali now.
Nice. Come on over.
So I'm part of the family and community medicine department up at UCSF now.
Oh, that's amazing.
So I'll be helping students and working on their policy program and everything. Yeah.
And I don't know if you're familiar with the Joint Medical Program, but it's a program that gives students a medical degree at UCSF and also an MPH. And it's led by Jyoti Marthan, who's amazing.
Oh, I want to learn more.
And all of these students are committed to community medicine. So I will.
Oh my gosh! Please,
I'll hook you up.
Please hook me up. I would love to talk about it. I take so much joy out of working with students. I'm excited, and I'd love to. Thank you for that.
Get more calls. Okay, thank you.
Thank you. Bye-bye.
Bye. We've now brought you more than 40 episodes of The Other 80. And thanks to you, we've just passed 10,000 listens. And one thing I love about doing this is seeing the patterns and threads connecting the conversations. Here's one. How do we bring all the parties to the table to create the conditions for health in our communities? And I'm not just talking about healthcare providers and policymakers. I also mean teachers, bankers, urban designers, food bank operators, which got me thinking. Do you have a story about how this has happened in your community? If you do, I would love it if you'd share it with us. Just send me a quick email. It's Claudia@theother80.com. This podcast was created by me, Claudia Williams. My podcast producer is Avery Moore-Kloss. There is more information on my background, this podcast, and our guests on our website, www.theother80.com. Until next time, I'm Claudia Williams.